Good afternoon, everyone. I'd like to let you know the meeting's being recorded. Thank you for joining the MHCC Health Equity Roundtable. My name is Melanie Cavalier, and I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission. I'm joined by my colleagues, David Sharp and Anana Onyabo. Dr. Pat Zapp will be facilitating the discussion today. Please contact Kelly Scott or send a chat message if you're having technical issues. You should have received an email earlier today with her contact information. I'm now going to call roll for the participants. I'm not sure if he's on here. Dr. Bazinski.
He's just joining.
He's just joining. Dr. Conway, I saw you on there.
Yep, I'm here.
Carol, Emily.
Here.
Dr. Jones.
Here.
Dr. Kana.
Here.
Angelica Newsom.
Here.
And Dr. Spots.
Yes, here.
And is Charles Gazzara on here? He was tentative. I don't think he's on here. Okay. So did I miss any participants that are on here?
Ken Bazinski, I just rolled on.
Oh, okay. Hi, Dr. Bazinski. How are you today?
Good, thank you.
At this time, I'm going to turn the meeting over to Dr. Pat Zapp, who is going to provide us a recap of the prior meetings and also facilitate today's discussion. Pat?
Hi, hello. It's good to see you all. Thanks for joining again. And just a reminder, since it's a roundtable, I'll be calling you by your first names, and of course, you'll call me Pat. So a recap quickly of meetings 1 and 2, because it's been a while since we've seen each other, and I'm looking at my notes. In the first meeting, Sarah, Ken, and Angelica helped us define health equity, highlighting providing opportunity and accessibility to care while recognizing autonomy and self-determination and personal definitions of health. And Monica and Tim discussed the importance of community partnerships to help historically marginalized populations overcome fear and distrust of the medical community. Angelica and Emily reminded us that reducing both the total cost of care and health disparities can only be achieved when social determinants of health are addressed. And Cheryl and Doug pointed out that multiple initiatives, both at the micro one-to-one in the exam room, as well as macro level, like societal investments, healthcare payment reform, are necessary to address health inequity. And you guys did that all in about half an hour. The second meeting, we talked for a bit longer, and we reviewed the results of a national survey of 1,500 physicians, 1/3 of them primary care. In that survey, virtually all physicians agreed that social determinants of health affect health outcomes, but they want to do something about that, but barriers get in the way, typically a lack of resources, including time and staff. And because barriers were getting in the way, there was this moral hazard that was a cause of physician burnout. And we pointed out, okay, that's one thing we need to address here in this roundtable. How do we address that? We talked about, thank you, Ken, Doug, Sarah, and Cheryl. We talked about offering practical health practices, ideally promoting ease of use, payer agnostic resources, not reinventing the wheel, right, Sarah, but rather tapping into existing agencies and resources. And Cheryl and Harpa also talked about how to engender trust in CBOs so that individuals and families feel comfortable asking for and receiving help. In particular, we discussed what role physicians can take in their community to be visible and trusted information resources when social determinants of health get in the way of health equity. So you did all that in 2 meetings. Just in terms of this third conversation that we're having, a reminder, our purpose, of course, is we're making recommendations to the state and the commission about how we can help those practices. And Melanie is so good about reminding me over time that the majority of practices in Maryland are actually onesie-twosies, both specialty and primary care. So there's a lot of mom and pop shops not affiliated with a health system or an ACO or a clinically integrated network or even a CTO. For whatever reason, it doesn't make sense now and may never make sense for them to join that type of organization. Yet they are taking care of most of the people in our state. So ironically, we're not only addressing inequities in the healthcare arena and what people are receiving, we're also looking at inequity among the practices themselves and how can we address that. So I just bring that out again. So to frame our discussion, we're not talking about how can we help the practice that's owned by a hospital and is on Epic so much as we're talking about those smaller practices. And we want to also make it easier for their patients to ask for and receive help. So again, we're looking at those micro in the exam room and macro approaches to addressing health equity. You've seen the questions we're going to be talking about. You've seen that we're also going to be discussing a little bit later in today's conversation what a symposium would look like and even a public service announcement. And I'm really going to peg Melanie to talk about that one. And I want to move to our questions, but in the meantime, I'm going to, I always like to do a little show and tell, right? So today's show and tell is I pretended I was one of those onesie twosie practices. And if you remember way back from our first discussion, our first show and tell was the ADI, Area Deprivation Index. And I said, okay, anything on the map, red is deprived, if you will, of resources. Anything brick red is really deprived. So I'm going to pretend I know nothing about my community's resources, and I'm just going to go ahead and see what I've got. So I looked at findhelp.org because I learned that's what Aunt Bertha turned into. If we can look at the second slide. And so looking at the ADI map, I picked Crisfield. And what you do is you just put in the zip code once you're on the site, which is easy to find. And next slide. And it opens up, well, I don't really think there are over 1,800 programs in Crisfield itself. I think there's some redundancy built in there. Probably they're citing county as well as state or even regional programs, but I was pretty impressed. And you'll see a red arrow up at the top left-hand corner. You can select the language that you want to look at, which I thought was great. And they have just about every language I could think of. And you can see there's all those different categories, food, housing, goods, etc., that you can tap into. So I decided I was taking care of a patient who had food insecurity. Go ahead to the next one. And so I just clicked on that box. And I learned that, if there's a caret next to something, that means there's something there. So help pay for food looked good. So I clicked on that. Next slide. And what I got was at first kind of disappointing. I'm like, well, my patient's not military and they don't have cancer. And I thought, geez, is that it? And then I looked down at the bottom where you see a red arrow. That's my red arrow. And like, food pantry. Okay, well, let's see what that is. So I clicked on that. And I found the Somerset County Food Program, which is very close to where my imaginary practice was. And you'll see down there, you can make notes, you can make a suggestion if you think that the site needs to be updated. And there's something called next steps. Go ahead. And you can print this information for your patient in any language, by the way, that you want. And it says, who's eligible? Is it available? How do I get it, etc. What's the cost? Some things aren't always free. What documents do I need to bring? And the next slide. So some observations as I was, looking around at this findhelp.org. I learned that they're best in class for social determinants of health networks this year and last year. I think Epic definitely has a relationship with them, but this is free for me or an individual member of the citizenry to log into. Apparently, there are some special services you can purchase, but I think they get most of their money from the people who are actually posting the resources themselves. It's very easy to access. There's multiple language. You can get information, like I found that food through multiple angles. And there's even a place where you can update information. Although I also learned that findhelp.org and 211 are going to be now comparing notes and helping each other keep updated. So there are resources that you can get to, even if you have very few resources in your practice. And that was encouraging to me. There was also a meeting, maybe some folks, actually I know some folks on this call attended on the 24th, which was all about how to find resources in the community. And a lot of the practices attending kept asking, how do we do this again? How do we do this again? So I thought it's really, I think, finding resources for your patients in the community is something you get better at, because the network grows, the more people you can connect with. And it always doesn't have to be you, the doctor, doing it. But anyway, that's my show and tell. Any comments about that before we go on to our questions?
Yeah, Pat, this is Ken. Quick question. That top line there, it was the social determinants of health networks. Is that like an organization or an association or something, or is that just a descriptor?
Just a category.
Okay.
Mhm,
Thank you.
Pat, it's Doug.
mhm.
I mean, that's really helpful. I had never heard of that. One of the things, just to not lose track of, and maybe you're going to go there with this, but I think is there's 211, right? And some of the payers in Maryland are saying, hey, we're going to go to Unite Us, and some are going to go to Aunt Bertha. And so we have all these different things. And one of the challenges is the interoperability and trying to say, okay, if we have multiple tools available to us, what's the source that's closest to us? This seemed to be pretty accurate in terms of local in my neighborhood, what I could really do. But it's really hard to capture, other than documenting in your chart, sort of the closed loop when you make a referral, and how do you know that this gets done? I mean, we'd all love to believe that in everyday practice, we're going to know if our patient, followed through with the resources we connected them to. But those are the challenges. Those are sort of the bigger part of the picture. So that's just my observation.
Absolutely. Thank
Not
you.
skepticism. I'm optimistic.
Absolutely. I get you. And, Melanie and Anana and I were doing some homework before this session, and we thought Chris might have the answer, and they eventually will have the answer with a closed loop and referral. And, we're not quite there yet. But
Yeah,
at least we have things like gethelp.org.
They reached out to us. They haven't solved it yet. I think they're talking to one of the bigger vendors, but then, I know that I was in sort of a subgroup with that, and everybody's concern is, do they talk to all of our systems, right? Not just Epic or not just Cerner. What about if you're in private practice and you have your own solution? So yeah, so more to come.
Exactly.
Yeah, and they also have to be able to, I was just gonna say, they also have to be able to talk to the different entities, like the food banks and all the other stuff as well, right? So even if you can get, all of the EMRs on there, the technical level that some of these community-based organizations would need to have to be able to receive those referrals and send them back is another challenge. So you'll probably not get to a point where you get to everyone, but if you have sort of a few of those things, like a housing network or, a standard, Maryland food bank, whatever it might be, you can at least get some closed loop activity, and that may grow over time as these organizations kind of, advance and get more complex.
Yeah, I agree.
And that is what they have in that CRISP network right now. Like they have the Maryland Food Bank, and they have the ones that are more advanced with that electronic. So you can do a referral online and they can close the loop. But again, it's only a handful of organizations at this time. So it's getting there, but it's not, right at this time, it's not really super useful, I don't think. I think Dr. Jones might have her hand up, Dr. Zapp.
Yes.
No, thank you. I think this was said already a little bit by Doug, but I just want to re-emphasize the resources clearly that are there and co-localized and easily accessible for us as physicians is important. But I do think I would want to rely on the state and stakeholders that can do this. I would want to rely on them getting the feedback from our patients about what works, what has helped them, what has improved their health. That's really, because then that's where we need to go back to, right? After we've learned what has really helped our patients.
Sure enough, and that's one of our topics of discussion. So let's put the PowerPoint away for now, if we can. And thank you. Is there somebody else with their hand up? It's hard for me to tell. Okay, Great. So let's launch into our questions. And of course, I'm going to pick on people, but, feel free to raise your hand. So when we're thinking about this virtual symposium, and we'll get down to the brass tacks of where, when, who about that, we want to be as helpful as we can to our audience, keeping in mind the onesie twosie type of practice. And what lessons would you want to share with practices considering how to address health equity concerns? In particular, Ken, I always look to you to inject some realism. What decision-making process should practices go through before addressing health equity concerns?
In terms of at the practice level, not in the individual patient level, you're saying?
Well, you've spoken to us before about how, gosh, you're almost afraid to ask. So is it a matter of knowing what you have to offer before you start asking, or you tell us?
To me, it comes down to the logistics of, that website was great, but how do I don't have time to help navigate with a patient and walk them through this and all this. What I'm seeing here is, that's the role for a, patient advocate, community health worker, one of those people who are the bridge people. I've noticed, I've see them growing at the hospital where I work. I'm assuming that like FQHCs have a lot of people who are, they're not nurses, they're not doctors, their job isn't to determine appropriate medication dosing. It's, oh, this is a patient who has a need. The provider has an idea of, which need we should work on first or which one's impacting their health the most. The patient and provider come up and say, hey, let's try and address food insecurity or my transportation. I need a specialist visit, but I can't get there. It's a common issue in our community. Somebody who, our nurse, somebody who could help work with the patient to get to that, I don't want to say advocate, but the facilitator, the connector, the person who makes it happen. That to me, like, that's the referral I would want as a provider. Like, oh, I think your child may have a serious liver problem. I had this conversation earlier today. You need to go an hour away to the big city of Morgantown, West Virginia, and gas is $5 a gallon, and you're not sure if your car is running, and there might be services there. There might be, community action provides a transportation bus. How can we get some subsidy for them for that, or help make sure they actually are there to get picked up? That to me is like that connector person. I work in the emergency department as well. We have a nurse navigator there, and they do a lot of that connecting. It's for a lot of these issues, and that's part of a bigger structure, a hospital who has funding for that. Maryland's total cost of care program helps promote hospitals addressing that, because they understand that the patient who doesn't have their social determinants of health met, they are going to keep coming back and overutilize emergency services as opposed to getting to some of their core issues. They'll come to the ER every time, but they'll never make it to a psychologist appointment to deal with the anxiety that drives them there. That was my experience on Saturday with one of my patients. So, to me, I do have a little bit of jealousy for the FQHCs, because I feel like they have this mandate to do these kind of things, and they have a strong funding source to do these kind of things. And so I find it very interesting that society has chosen to fund FQHCs at this very high level and very high staffing. And, those who are not, you get your fee for service and that's it. That's why I'm so excited about the Maryland primary care program, about the heart money. We're starting to bridge into that to acknowledge and advocate that these, there's a lot behind health equity other than people's independent decisions. There is a lot of societal and cultural factors and experiential factors. So we know it. And so to me, it's like we need somebody there in the middle in my little practice who I can call them up and say, hey, I've got this patient. They need help with this. Can you help them navigate this system? I mean, just even, you're an educated person, Pat, you worked through that website, you got to where you needed, would someone look at that little box in the bottom? You're like, oh, I don't have cancer. I'm not military. I'm done. It's not for me. It's like you need someone who's, you don't need a paid social worker to do this. You just need someone who's, caring and connected in the community. And I think that relationship, then that helps, they act as an extension advocate of the provider, and they can help bridge some of those trust gaps that we talked to. I've seen that happen in my practice with my care manager in my practice. She just develops rapport, builds trust, influences outcomes tremendously. So I don't know, I'm long-winded, but that's where I see it. I need this connector person to bridge the gap between very practical resources and what, providers see as impacting people's health, even if people don't see it themselves, but also addressing what people themselves see.
Exactly. Well, on the West, they call that person a promotora. On the East Coast, we call them CHWs, and we can talk a little bit more about
What was that? What was that other term you said?
promotora. And yeah, for the Hispanic.
Oh, gotcha.
Yeah, exactly. So, but basically, it's a community health worker out there, a lay person who is, they get paid to do this job of connecting. And Sarah was itching to say something.
Yeah, I just, I think actually Ken got a lot of the things I was going to say. As I'm reading that bullet, I think about, capacity and resources, but I think the other piece that Ken touched on that I thought about as well is skill sets. So understanding the skill sets if you're sort of, again, trying to think back from like the onesie twosie practice perspective, right? Like if you have somebody in your office, is there somebody who's going to be, good at the internet, who can go and do the findhelp.org stuff? Is there somebody who is good at interacting with patients and asking them delicate questions about their life or their food insecurity or their housing, who can do that work? Is there somebody like that in your office? And then sort of defining the role that they have in supporting the patient, so that, when Ken's finished seeing his patient, he can say, please go see Joe, or have Joe come into the room, and then he can help that person do that, print it out in whatever language they need, et cetera. So that was the one thing that I was going to add there. And then I think, again, still staying in that mindset, assuming that a practice doesn't have, a community health worker and a care manager and a social worker and all of those different things, you can leverage the hospital, which is great in an urgent sort of scenario or a place where it has to happen, but we ideally don't want to leverage the hospital and its resources, particularly in a total cost of care state, and thinking about value and cost to the patients, et cetera. But then thinking about, are there other obvious places you could call? So there's, whatever your state or municipality is to support them. There's, referring them to another facility like an FQHC. But I think the other thing is calling their insurer is the other thing that I would just sort of say is on there, because again, many of the Medicaid managed care organizations, many of the private insurance, et cetera, have different programs that would try to help the patients, whether or not it's care management or other things. And so I just add that to the list of people you could call that are not necessarily affiliated directly with the hospital.
Thank you for bringing that up, because it is true that the government is placing more demands on payers to address social determinants of health. And so making them more accountable is also an achievable mechanism.
And sometimes, I was just gonna say, sometimes they have like duplicative resources as well, right? Because they feel, they're actually, they're at risk for the cost in many of these capitated models, et cetera. And so they build out these programs that are oftentimes very comparable to what practices or others build out, because they're trying to control that patient's behavior as well. And it's for many reasons, I think structural and otherwise, challenging for them to sometimes interdigitate with the provider side. So just remembering that and saying, like we can sort of try to punt it back into their hands as well, because they're, that they have a risk relationship and a relationship with the patient as well.
And just pointing out to them, hey, I have somebody who's going to be really expensive unless we address X, Y, Z. Ken, you wanted to add something?
Yeah, I just about twitched off my seat when I heard call the insurer.
I knew you would.
Oh yeah, they might be interested in social determinants of expense. It's where the rubber meets. That's the language they talk. But I have had patients who are in some of these care management programs. They're the very sick, high utilizer, high risk. individuals, and the care management has been very good. The Blue Cross Blue Shield care management out here has been good. We've done some partnerships with our FQHC here with the Maryland Physicians Care, Medicaid, MCO. But if you're talking calling an insurance company, I don't think those people who have limited social resources and capital, that's going to be hard for them to navigate. They need that community health worker.
Yeah.
They need somebody who
Agreed.
can spend the time and fight the fight to get what they need. So
Mhm. Yeah,
thank you.
and we'll address that a little bit more. So, Cheryl, you spent a lot of time a week ago talking with folks on a big call about how practices identify social resources for their patients. And do you want to recap your advice about, where do they start?
Yeah, and if you don't mind, because I just had a couple thoughts from the
Sure.
discussion just then. I am part of one of those hospital-based teams that provides outpatient community case management. So we kind of do a combination of, I guess more of our inpatient case management team manages the patients when they're here, and then we help out offices and just kind of the community at large when the patients are in the community. So, and all hospitals operate a little bit differently, but we are one of those groups that that you can pull hospital resources in without having to send the patient to the hospital, because we also don't want patients to have to come in unless they actually need that level of medical treatment. And we kind of have, and this is through the Maryland Primary Care Program, we have relationships with our MD PCP practices where we're trying to support and grow those practice staff to do the level of kind of resource navigation that they're able to. And then our team of social workers and navigators can do those more complex cases that sometimes are beyond maybe just looking for a resource and giving it to the patient and doing that community health worker level stuff. So I find the combination works pretty well. Of course, we're still figuring it out, but it is nice to have some of those clinical level services as well, especially when you're getting into behavioral health. I think the community health workers are fantastic in that a lot of times they're from the community. They may have had lived experiences with some of the social determinants and some of the barriers that the patients are experiencing, and that's very powerful to leverage in that relationship. But then to have that clinician support as well, I think can also be really important. But how all that comes together, that's the magic question. So, okay, getting back to the question you actually asked me. Yeah, so I think what our presentation was about the other day was how to go about starting this process of identifying the social resources. I think what we found most helpful here, and again, every community is different, but is to really kind of start finding out what already exists and establishing relationships with some of those key agencies in the community, like the Department of Human Resources, DSS, the Bureau of Aging, our local health department, because they already have so much programming, and not only to become familiar with the programs, but to find a couple people in those agencies to actually connect to. So then those individual relationships can be so helpful when you've got either you as the provider or whoever in your office is helping to do some of that resource navigation. If you're stuck, or Aunt Bertha or findhelp.org isn't coming up with anything, to call that contact person at the health department and say, hey, this is what we're trying to figure out. Can you help, or can you direct me to the right kind of agency for this specific need? Especially when the needs start getting more complex, or the patient said, oh, I've been working on this and I've called 10 agencies and I haven't gotten any calls back, which is a lot of times, unfortunately, what happens, either because the agencies aren't responsive, or the patient has been calling the wrong number, or they can't receive voicemails on their phone. There are just a million reasons that connections don't get made. So that would, in my experience, is the most powerful way to get started, is to start creating that familiarity and those relationships. Then you've also got somebody that is going to call you back, because that's the other really hard thing. You call places and you never get a call back. And sometimes those relationships can really help. A lot of times they are going to want that relationship with you as well, because they're probably not very connected to the medical community the way they would want to be to help service their patients.
And it's not unheard of to trade cell phone numbers as well with those folks. Monica, you had your hand up earlier.
It will seem a bit off topic if I interject now, but I'll just, much of what has been said already, critically important. I think Ken brought this up, and that is the issue of where folks trust and where community is built, right? Those are basically the two places where folks are going to seek information and where they're going to go to repeatedly to get information. And just to piggyback on what Cheryl said, whenever patients run into the runaround, that's where they will disengage.
Right.
When clinicians run into the runaround, that's where they'll disengage. So wherever we can create a space where that's not happening is, I think, where we're going to want to be to improve health and decrease inequities.
Well, to your point, maybe I'll ask Sarah to comment on this. How do we know, as a small onesie twosie mom and pop practice, which resources are effective and which ones aren't?
I think that's probably a very manual, experiential process. I think in maybe the advantage that the smaller practices have is that it's not distributed across a lot of people discovering the same thing many times over. If you have one nurse in your office who is calling these things and then no one ever calls her back, she has learned that does not work. So, perhaps there's that, but I think to the point earlier about the lack of, formal feedback loops, and I think in a lot of these things, it is going to be based on that office's particular experience or feedback from the patients who they have sent to those resources to provide clarity on what is effective and what's not. I think this has been sort of the challenge with a lot of this over time, is it feels very manual and like people are relearning the same lessons as the resources in each community shift, as all of these things happen. But I don't know that there is a super obvious way, though one could think, to create, a structure where you can track that, right? Like if you're sending people, getting feedback in a more formal way within an office may help you sort of more clearly demonstrate what are the good buckets or good organizations to connect with and what are not.
Mm-hmm.
And Monica, you have your hand up again.
Yeah, to that point, I would just say, we as consumers get asked that all the time, right? We say, can you fill out this short survey? Can you just give us your response on what your experience was? 5 stars, 4 stars, 3 stars. Very, very simply and very literacy appropriate to really ask those questions. But one of the things, as I was listening to the tape on this group's discussion about data and data gathering, we rely so much on quantitative data rather than qualitative data. And so what I think, as you build in these processes, one, set the expectation with patients that you're going to be asked your opinion about your experience, one, and then two, really do that with maybe small focus groups or something that can be led by the community social worker as a way to get that feedback around what resources are helpful or what our patients are finding helpful. I think is going to be where we're really going to get the information rather than necessarily through a quantitative mechanism.
Mm-hmm. And what happens a lot of times with especially the smaller CBOs is they'll be great for a while, but then all of a sudden something seems to dry up. Maybe they stop taking referrals. Maybe their funding got soft. We don't know that if we don't have a personal connection there. We can't call Susie in the front desk, say, what's going on with you guys? So I'll ask Emily, how do you think practices should go about how do you call a CBO and say, hi, I work with Dr. So-and-so. We're just wondering what you got over there. How do people start that out?
Good question. I don't know if I'm, the right person to answer this question, but I think you start somewhere. You identify a resource, and it's about networking and picking up the phone and seeing who answers, talking through what the needs in the community are, and if there are potential partnerships. And of course, you're going to get as many misses as you get hits. But, from my perspective, it's about starting somewhere and potentially, focusing in. Maybe it's, you see there's a need in the community for food resources, and not trying to tackle every social need for your patient population at once, but how do we find an appropriate referral resources for food assistance for our patients, and start small and then kind of expand from there.
And I think Angelica had her hand up.
So in the past, I've taken the approach of doing meet and greets with the resources that are in the communities that I'm serving, and finding a point person that I can connect with. And it was a lot of boots on the ground type of work. And I know that depending on the geographical location, that's not always feasible, but then in another respect, I think that turns into finding those community members. So thinking of like my rural populations, the church playing a bigger role, or any type of religious affiliation, and finding that person on that ministry group that's focused on health, because a lot of them do have those kind of groups, to connect with them in terms of what resources they know about, what community members might be able to provide support for whatever social determinant need that that person has. And really, as a social worker, I'm constantly talking to other social workers about what they're using, what they have used, what they're not using anymore. If I have a negative experience with a resource, then I need to let my colleagues know that, because word of mouth matters. And then also, I always try to keep up to date with who's still working at organizations, because that's always changing. And so if this is an organization that you have a relationship with, continuing that relationship over and over again is helpful. And even just having the group introduce themselves, not just to the social worker, but the doctor, but the front desk staff. So everyone's kind of aware of like who the major player, who's been very helpful. I tend to not feel like our social services does what it needs to do for patients, because it's just not that personal knowledge of what they're going through. So if I am referring someone to DSS, I like to have a name of who the patient has talked to, so we know exactly who we're following up with. Or in the past, I literally carved out time in my day, and that's specific to my role as a social worker or a role of a CHW, to go with someone and be that face-to-face advocate, if possible, when they're interacting with that resource. So then there's even more buy-in. I'm doing this warm handoff, and that all parties are kind of aware that I'm playing some sort of role. I'm keeping track of how this goes.
Gotcha. Yeah, and there's also a kindling effect. I think you kind of alluded to this when you have a good contact in one place, and then they become a resource for other things because they have their contacts, and then word of mouth just spreads really easily. The coordinating center is they take care of basically the entire state of Maryland, and they use their network all the time. They just throw out a question, hey, who can help me figure out blah, blah, blah. And it's amazing how that can work in a network situation. And networks, you don't have to be some big organization to have a network. You're just a human being. And Melanie had her hand up.
I just wanted to point out that there's been kind of a little sidebar conversation in the chat about PFACs and using PFACs.
Yeah.
And I think this is an amazing use for a PFAC, and that they can, this is really one area that I really, I certainly agree with the experts at this, they can definitely give you input on some of these community resources and how useful they are, how good they are, vetting them, that type of thing. But I also wanted to point out that I think that we may have missed a question before we get too much into talking about the before we get too much talking about the symposium. And then Dr. Bazinski put in there who communicates with the patients, a staff member or clinical providers. I believe you're referring to the PFAC itself, Dr. Bazinski.
Yes, who communicates with the patients in the PFAC? Yeah.
Yeah, so I would encourage the two people who talked about their feedbacks maybe to just touch on this briefly. Dr. Conway, if you want to start and talk about who was in charge of the PFAC at your organization. And then I think it was Dr. Jones who was talking about a PFAC as well. Go ahead.
Yeah, I'd probably defer to Dr. Jones. Yeah, if Dr. Jones, you want to go first? I'll let you kind of. I haven't been to our PFACs, so I know that they do them.
Yeah, so I'll speak mainly to our women's and children's PFAC team since I've sort of attended some of those. So basically, there have been patients that are invited that have had either a great experience or a horrible experience with our organization, and they meet monthly. And actually, what we present to them as a service line is, so this was new that's going on in the service line. How do you believe that this would be received? How do you believe people will be helped? And we just ask them those questions. And of course, we provide them the information in advance of the meeting. But they give them, this is my experience with the health system. Yes, you can do that. Or if you're going to do that, you'll need to include this. They're highly informative for us. And we reach out to patients that have both great experiences and horrible experiences so we can learn from both of them.
And Dr. Bazinski, I think for different PFACs, it depends on the organization. Sometimes they have a provider that's in charge of their PFAC. Sometimes they have like a care manager that's in charge. Sometimes it's an MA or an office manager. But I think that varies a lot by the size and the resources of that organization. We actually have some information on PFACs that we'd be happy to send you. So we have a guide on PFACs that we developed at the commission.
And you may have said this already, the Patient Family Advisory Council.
Patient Family Advisory
acronyms out. So
yeah, sorry. Thank you for pointing that out, Dr. Jones. Thank you very much, actually, for pointing that out. Yeah. But before we go too far into the symposium, I do want to go back. I think we missed a question about how do we identify patterns of need in the community.
Naharka, we haven't heard from you. Is she still there?
I was waiting to be called on. So we actually use ADI in our practice, and we have been maintaining a very updated list of patients that have come back to our practice during COVID, and those who went away and then came back. And we've been remapping them on the ADI pretty stringently. MDPCP has really helped us to start to use the care management group in our practice. We now have a group of 6 or 7 nurses, one of whom is the designated care manager, who actually reaches out to patients on an absolutely regular basis. So what we do is to identify patients who have multiple chronic diseases using the MDPCP list, the Care First list, the Mary Group list, and we ask her to call all of these chronic disease patients to identify what their needs are. And in a sense, that has been our guide for developing all of the resources that we have in our practice, in addition to connecting needy patients to appropriate resources, and then having the care manager go back and make sure it happened, did it work. Some of this was also driven by a remote patient monitoring grant that we got from FCC, for which we needed to give out hotspots, and we needed to give out the remote patient monitoring equipment to eligible candidates, which meant we had to identify who they were. So using that ADI index, we were looking at ADI indices 8 to 10, and patients who lived there had chronic disease, and use that as our starting point. Mm-hmm. And then of course you have your discharges who regularly go through a post-discharge clinic, who typically have certain needs. So those are additional people to use some special resources within the practice. So those were some of the ways that we used to identify our high need patients.
Thank you. And I think PFACs could be also a source, especially for the smaller practice that maybe doesn't have all the resources that you listed.
Yeah, we actually have a very good PFAC as well, and I really like that
Mhm.
discussion on PFAC. So our PFAC has been very helpful to advise us on emerging needs. Sometimes they have a better sense of what's happening than we do.
Yeah, exactly. And I'm being mindful of time, and I wanted to pick on Angelica for another minute. And assuming at least there are some social resources and CBOs in every community, even the high ADI communities. How do practices make it easier for patients to know about and feel comfortable asking for and receiving help?
I think that comes down to the types of questions that we ask and how we ask them. Not even just language, but of course, body language. What setting are we in? And so, assuming that in this hypothetical situation, this practice has all the other teammates, they have social work and a community health worker at their disposal, then it's the provider being able to ask that direct, like yes or no question, because we know that you're in a time limited appointment and you kind of want this question to kind of trigger the right referral of where we're going next. And so I think from there, based on that yes or no question, you're kind of going down this tree to know, am I handing this off to a social worker? Do I have a resource off the top of my head? Like I know this food bank has warm dinners at 6 o'clock every day. So I can give that to the patient and let the social worker know, or let the community health worker know they can follow up later. Is this something that needs to be dealt with in that moment? So it's all about asking the right question and then the way you ask it too, so that it's not accusatory. There's no shame that we're building up in that room. It's just really keeping it, this is about your total health. And it always comes back to that, like your total person.
Cool. I like that. Very respectful. Yeah. So as we think about putting together a symposium with our audience of the onesie twosie smaller practices, and we think about the resources we want to describe or the approaches we want to describe, we're trying to think about maybe having a symposium, a virtual one, later this summer, early this fall, and had some thoughts about potential speakers who might be able to talk about, again, how that, again, the micro and the macro. How do you interact one-on-one in a respectful way and address social determinants of health? And then how does your practice interact with the larger community? And I just want to ask if we have on the line here folks who are interested in speaking at that symposium.
Are we thinking, we don't have a date identified, because I'm thinking of some other synergies, Pat. We may not all fall in this category, but Family Medicine Education Consortium is in Arlington, Crystal City, and is a regional representative. I'm on that steering committee at 16 to 18 August, and then the national meeting is there too. So they're beyond just this group. Particularly in that FMEC group, there could be some synergies. I know they're still looking for innovation speakers, and it's open to not just one individual speaking versus sort of like a roundtable or a discussion. So that's just a thought. And that's a long way of saying yes, depending on the dates and what we would choose as a date in terms of speaking or being a part of a panel discussion or something with recommendations. I think to take this great thought and take it to actionable steps would be really sort of exciting.
Great. And Angelica, you have your hand up too.
Yeah, I would love to contribute whatever I can.
That's great. Other folks?
I'm happy to help if that would be beneficial. Happy to chime in and speak.
Great. And believe me, we'll talk a lot more probably as a smaller group about what that would look like. So we're not, you're not signing up for giving a 2-hour lecture or anything like that.
Mhm.
Speaking of length though, what works? An hour, 90 minutes, 2 hours? What does the group feel like?
I think an hour is probably max. Oh, you mean to speak or for this meeting?
No, for the entire symposium itself.
Oh, okay.
Sorry, I was not clear.
So I think
would-
it depends. I think it depends on what what you want to cover. And the folks you want to target. So if we're targeting the 1s and 2s, and sort of family medicine, the whole families, you've got women's health, children, and then, adult health. And then if you want to certainly touch on all the social determinants, having folks that could speak to that as well. I do find that an hour isn't enough. I did a town hall to get children vaccinated, for example, for COVID, and I invited everybody to it. And by the time, I think we did it for an hour, by the time the hour got there, we were just like, oh no, but I wanted to ask. I mean, it was an amazing town hall, but there were a lot of questions that remained. So if we're going to tackle a lot and make sure our 1s and 2s practices get what they need, I think 1 hour might be short. 90 minutes might be a little bit better. And then the content.
Mhm.
Yeah,
I agree.
what's the goal in this? Is it to solicit information, or is it to provide information, or to have a discussion? I'm just sort of, when you say symposium, I'm not sure whether it's,
Right.
what's
So,
the goal of it?
the whole purpose of our roundtable is to make recommendations about how we can support practices that want to improve or decrease health disparities, I should say, in their own communities. So it's more informational, but question and answer for sure. The audience, again, those smaller practices that are actually raising their hands saying, I need help, or I need to do something differently, as poignantly a family doc said to the state, help me out here. So it's more informational, but with time for questions and answers. So it's not like taking a day away from your practice, but maybe it is that 90 minutes where we're talking about what happens in the exam room, and then how does your practice interact with these CBOs, community-based organizations, to actually get resources for your patients.
So it's like a PFAC for practices.
A little bit, right, where yes, a little bit where you're getting that we like to ask the practicing providers, like the people that you see on this call, to talk to other providers and tell them what works, what they've done, give them some suggestions and action items, and like some of the things you've heard. How do you get started? What do you do? How do you connect to people? What's the best way to engage your community? I mean, it won't be specific to a community. I mean, some of them might be specific to a community, but not everyone's in the same community, right? So it's got to be some more general steps as well. So Dr. Spots just said 90 minutes for what we're talking about. So, I think that seems to be consensus. So if anybody doesn't agree with the 90-minute suggestion, please let us know.
Mm-hmm. Yeah.
Okay.
Does that make sense? And again, I know we're running low on time. There's no rush to do this. I mean, we don't have to do it in the summer. August tends to get really busy. Is September a better time where people are thinking of fresh beginnings in September? What are your thoughts?
Mm-hmm. September or January, those are both. January is always a nice fresh start, as well as September. Yeah.
Yeah. Angelica's saying September is better too. Okay. And any recommendations about how we advertise this or get the word out other than the usual emails?
So we do have a listserv that we use that includes practices that have been to prior events. So we're just looking for, is there a different way that you think practices would receive this information other than, email from the commission?
Are we targeting MDPCP programs, practices?
Well, we have
Yeah.
partnered with them and they've distributed it on our behalf as well. So I saw Emily just sent that as well.
Yeah.
So we have had
Great
them
minds.
do distribution. So that is one thing we've leveraged before. Like we've leveraged MedChi and some of the other associations.
One of the
MDAC.
strategies, I was sitting there looking at the heart money I got and I was like, oh, now what do I do? Like, wow, I've never had money to address this before. I don't know what to do. It could be a symposium to help these MDPCP practices, like how to effectively invest your heart money where it's supposed to go. Because even though it's not like grant line item accounting, there is a spirit behind it of, this money is there to help address some of these things. And, the commission is not just saying, here's the money, better spend it right. This symposium is a way to help discuss and, in terms of like, how does it get relevant for those who are the actual on the receiving end of MDPCP as practices? Maybe it's tie it to the heart money. Cause that's a huge paradigm shift for private practices, for, non-FQHC practices, actually get money to address something other than your visit in the room with a patient. This is radical.
Yeah, I think that's definitely one angle to bring them in. But remember, we're also talking about the mom and pop specialty practices as well, and the primary care practices that might not be in the Maryland primary care program yet. But this would that's definitely an interesting angle.
Mhm.
Angelica's running into another meeting.
Yeah, I think we have a lot of people who have overlaps.
Yeah. So we better.
Conversation. I think that we probably need to wrap it up with respect for people who.
Exactly. We don't want to run over, which we already have done. So again, a lot of information. We've got some ideas. We're going to meet again in July. And we can discuss a little bit more about the symposium and also another really interesting public service announcement opportunity. Melanie, David, any thoughts?
I just wanted to thank everyone again for sharing their thoughts and perspectives. The recording and a summary of this meeting will be available on the MHCC website. The next meeting is scheduled for July 13th from 1 to 2. We'll continue this great discussion. David, anything before we?
Outstanding conversation. It's Pat, terrific job to the participants, just amazing dialogue. So thank you all. I think we're headed someplace great. And I encourage you to continue to hang in there with us. And I appreciate all your hard work. So with that, I'll turn it back to Melanie.
Thanks so much, everyone. And we'll see you in July. I hope everyone stays well and has a great summer. Thank you. Bye, everyone.
Bye.